Hello, I'm Amanda Oakley and I'm here to talk about practical tips for teledermoscopy. I have some conflicts as I'm a consultant for a teledermoscopy company called MoleMap New Zealand, and I've received dermatoscopes from various companies. I'm very experienced in teledermoscopy, having worked for MoleMap as a consultant since 2003 and having had referrals at Waikato Hospital, a public hospital, using teledermoscopy since 2010. Please note that I practice in New Zealand and will describe the teledermoscopy systems I use here. They may not be relevant or even legal in your jurisdiction. This is the outline of my webcast. Let's start with definitions. Teledermoscopy is dermoscopy at a distance, and it reflects dermoscopy images of lesions, rashes, infections and infestations of the skin, hair and nails. Digital dermoscopy is the use of digital photography. Teledermoscopy can be from a patient to a clinician or from a clinician to a clinician, usually primary care to a specialist, but sometimes dermatologist to dermatologist. There are various contexts in which teledermoscopy may be useful. The most common is to get a second opinion for a single lesion, to make or confirm a diagnosis, perhaps to allay patient concern, avoid unnecessary surgery if the lesion is benign, or confirm it's necessary if it's a suspected malignancy. Sometimes it's done for funding purposes. Teledermoscopy can be useful for archiving multiple lesions in people at high risk of malignancy, particularly melanoma. They may attend for a full skin check, whole body photography, and then macro and dermoscopy photographs of a lesion or lesions of concern. It may be short-term follow-up to confirm a particular lesion is stable or changing, or it may be an annual whole-body skin check with dermoscopy and macro images of the lesions previously archived and any new ones. It's really useful to reassure the worried while who might otherwise have multiple unnecessary excisions. Let's start with a teledermoscopy referral. The patient attends the primary care doctor who decides to refer to dermatology. He completes a template and attaches images, sending it to the dermatologist who responds with advice. The first thing to be clear on is consent is required for referral. In addition, if you might use those images for any other purpose, such as publication, it is important to ensure the patient is aware of that. Equipment. First of all, a dermatoscope is essential for teledermoscopy. Almost any dermatoscope will do, but to some extent you get what you pay for. You need the scope, an adapter for your chosen camera, which is often a smartphone. You should choose polarized dermoscopy, or better, polarized and unpolarized dermoscopy, and you'll get better pictures if you use the contact method of photography. These images show expensive and less expensive dermatoscopes that can be used for this purpose. You need information communications technology to archive the system, to store the image perhaps in the patient's electronic medical record, which is ideal. And secure off-site archiving is also offered by various companies. It should be fit for purpose, secure and private. Public email is not secure, and personal health information, such as a name, a specific health number, or an identifiable picture should not be sent over public email. It's important to determine the quality of the images that you're sending. Most people take JPEG images. PNG is a little bit higher in quality, but also larger files. Best to avoid GIF images, which are not intended for photography, and PDF files. Compression of your images will reduce the file size and may not change the ability to diagnose the condition. Consider patient privacy. A close-up of part of the face may be totally acceptable as a location view if it shows anatomic markers. Your images should be good quality, in focus, properly exposed, and without redundant backgrounds such as clothing. We prefer high-resolution files, 2000 by 1500 pixels to 4000 by 3000 pixels. If a file is larger than 5 megabytes, you may decide to reduce its size, but you can't increase smaller-sized images. We need regional views to reduce error, to identify the location of the lesion and evaluate the surrounding skin. Is the lesion of concern different from the other lesions on the patient's skin? We need close-up views. A close-up view determines the lesion's morphology, its surface characteristics, its effect on surrounding skin, such as has it caused an eczematous response. Oblique or side-on views will show the lesion's height when appropriate. Now, if your close-up is not in focus, try backing off and zooming in. You may need to practice. Dermoscopy views can be polarized or unpolarized, and better both. The dermoscopy views will usually result in a confident diagnosis, an unpolarized view showing the skin surface characteristics and a polarized view showing the subsurface structures. Remember, apply fluid to the lesion before dermoscopy imaging. If it's a large lesion, you will need to take multiple images to cover the entire extent of the lesion. Here's an example of the GP's suspected skin cancer template they must complete, and location, close-up and dermoscopy images. Here's an example of mole map system with whole body photography, macroscopic images and dermoscopic images of 4 different patients. Another very successful teledermoscopy system used in New Zealand is Derm Engine. So the referrer must include some essential medical history points. The patient demographics and risk factors for malignancy will point towards the chance of a particular borderline lesion needing excision. Does the patient have a history of melanoma, other skin cancers, or other risk factors for skin cancer? We need the clinical details such as medications, current health problems. The lesion history essential should include the lesion location, its duration and when it started, the size of the lesion at the time of evaluation, its appearance and behaviour. A dermatologist will be responding to a teledermoscopy referral in most cases, although sometimes it's another specialist, even a well-trained general practitioner. Here's an example of a dermatologist responding to a referral through our public electronic referral system. On the left side, you can see a referral of the suspected skin cancer template that has been completed by the referring primary care physician. In the middle, we've used a macro system called TextBlaze, which is remarkable at reducing the time to complete a report. We provide very comprehensive reports, and one of these is shown on the right-hand side of this image. MoleMap also provides very comprehensive reports. In this case, we're seeing part of a long report in which many lesions were imaged and some required action, such as immediate treatment of a lesion suspicious of melanoma. A teledermoscopy report should have 3 or 4 components. It should include a description of the lesion or lesions and the purported clinical and dermoscopic diagnosis, followed by a care plan. Do you recommend excision of this lesion, monitoring, or can you reassure the referrer and patient that it's harmless? What follow-up should you arrange? We provide patient information explaining to the patient what we have found and what should be done about it. The example here is a subungual hemorrhage. I'm pleased to acknowledge my colleagues at Te Whatu Ora Health New Zealand. Best practice that provides us with the referral system, MoleMap for its archiving and lesion of concern system, and Derm Engine